So good morning and good evening to everybody who's logged in today from whichever part of the world. And Dr. Truptesh and I are happy to welcome you to this session, one more session of our webinar called East Meets West. We've been doing this for the last 2.5 years, and we've had a lot of faculty from the East as well as from the West who have been part of these webinars, and we try and always have one topic which of common interest to both sides. And the idea of this webinar is basically to highlight the technique differences and the practice differences between the East and the West. And so today's webinar, as you all know, is on POEM, tips and tricks. So POEM, as we all know, is one of the most popular procedures in the last 1.5 decades of interventional endoscopy. It's probably the most popular technique, and we have global experts today with us to share their views and their ideas and tips and tricks on POEM. So from the East, we have Dr. Mohan Ramchandani from the Asian Institute of Gastroenterology, Hyderabad, India, as one of our experts. And the other expert from the East is Dr. Ahmad Madkour from Cairo, Egypt, a very good friend and an extremely talented endoscopist. And welcome, Mohan. Welcome, Ahmad. And Truptesh, you want to introduce and welcome your Western friends? And
thank you, Amol. And this gentleman or this physician doesn't even need an introduction. He's the pioneer of POEM in the Western Hemisphere, Dr. Stavropoulos. He's the third space and endoscopic surgery program at Mount Sinai, South Nassau, Oceanside in New York. And we have always looked up to Dr. Stavropoulos as the maverick for POEM, especially in the Western Hemisphere. And I was a fellow when he actually did his first POEM. So it was a great pleasure and honor for me to invite him as one of our faculties for the STAR program. And then our second faculty, who is actually stuck in an emergency right now, and hopefully he can join us, but I would still like to introduce him, is Carlos Robles-Medranda. He's the head of the endoscopy division and also the CEO of his institution, that is the Instituto Ecuatoriano de Digestivas in Ecuador, South America. So with no time lost, I would actually invite both of you and all the faculties who have actually taken out time on a Saturday to impart knowledge to all of our attendees. And I would have Dr. Mohan Ramchandani open the podium and go on with his first talk on the techniques of POEM.
Okay, so at the outset, I thank Truptesh, Amol for giving me this wonderful opportunity, and I'm really honored to share this with my hero, Dr. Stavros, and also good friend, Dr. Ahmad and Carlos. Thank you very much, and we'll start this webinar going step by step. I think as we started this procedure, I'll quickly talk about the introduction, how it started, and then how I select my patients. I'll talk about some of the technique, which may vary from Dr. Stavros. We'll talk about some of the adverse event. I know bleed and mucosal injuries will be covered. And I'll talk about some progress, what we are making in POEM. I think it's all started with the concept where we are able to split the gastric or the bowel wall into layers. Now we are able to do layering and able to treat these disorders which are restricted to one of the layers. Say, for example, disease restricted to the mucosa can be removed by this tunneling method, where you keep the muscle intact and remove the mucosa, while if you are able to separate the mucosal layer from muscle layer and treat the muscle layer and keep the mucosal layer intact, then it is known as POEM, where we can treat the muscle layer. But the good thing is that you have to respect other layer. Here in ESD, you have to respect the muscle layer. Here you have to respect the mucosal layer because they are the ultimate barrier which are going to remain once you remove the other layer. So whole technique involves the separation of the layers. If you are able to do that, you will be able to treat it. So achalasia cardia still, if somebody gave me a wish, I will be able to treat the achalasia with bringing back the peristalsis, bringing back the LES relaxation and contraction ability, but it's not going to happen. So we have an incurable disorder, and what we have is only palliative treatments. And treatments can vary from balloon dilatation to Heller's myotomy. POEM is another endoscopic procedure where the similar goal of removing the muscle, keeping the mucosa intact, is achieved orally with a scarless procedure, while the similar things are done by peritoneal approach when you insert a laparoscope. Balloon dilatation as a standalone single dilatation is losing its reputation. Still, it can be used if properly done in type 2 achalasia with graded fashion, where patient may need to come to hospital many times. So let's talk about the POEM. POEM can be done in a very small place where there can be an endoscope and some of the accessories like transparent caps. The knives which are preferred in POEM over ESD are slightly longer in length, where you can work at a distance. So TTJ knife and RB knife, the legacy knife, which is older one with a longer shaft, is my preferred knives, where jet facility is also available, so you need not to exchange them. The smaller knife, like dual J knife and all, I prefer more in ESD. I keep ready clips to close the defect, and I have also quack grasper. So if these are things are there, I'm ready to start POEM. And I must have a scope with irrigation capabilities and also electrocautery unit, which can give us some of the currents. I usually use for incision, if I am using RB knife, endocut I, effect 1, duration 3, and interval 3. So these are my mucosal incision preference. And for dissection, once I get into the tunnel, I use more of swift coagulation or a precise sec now if you have a YO, but if you have 200 or 300D, then you may use a spray coagulation or a swift coagulation, or even a forced coagulation if you have 200D. The similar things are available in another company's generator where you can use these. But once you are having a bleeding or you want to preemptively coagulate, you have to use soft coagulation. So these are some of the settings which we must be ready. And if I want to do a POEM, I must have these three: high resolution manometry, a time barium swallow, and a OGD in a patient whom I am planning to do a POEM. I quickly do a survey of the available manometry and quickly classify these patients into type 1, type 2, type 3. As you know, type 2 is the earliest form of achalasia. I try to do shorter myotomies here. And type 3 achalasia cardia is a totally different pathophysiology, where long spastic segments are there in esophagus. So I always plan a long myotomy. So HRM is a must for POEM. And the second thing which I want to see is time barium swallow to objectively say what is the stasis and how much is the, to quantify the stasis part, which is of utmost importance to me, because once I do the procedure, I can also compare as an objective response. The endoscopy I do to rule out any esophageal candidiasis, which is an relative contraindication. I don't want to do a POEM with such severe esophageal candidiasis. I will stop there. I also want to see whether there are scarring or there are chances of submucosal fibrosis. I also do an endoscopy to rule out a diverticulum and see the tortuosity of esophagus. If the esophagus is too tortuous, then my technical success may be okay, but clinical success will be slightly low because there is no direct vertical segment, and there are many horizontal vectors which may prevent emptying even if you do a good LES myotomy. So let us plan the poem. Once we have all these three available, I will do the planning as I said, by inspection. I have already inspected. I will take a history whether this patient has prior laparoscopic Heller's myotomy, which will decide my approach. I will talk about these things and then see. So the most important thing is I will see is which circumference part, whether I want to do anterior or posterior or length. What are the length of myotomy? So this is how esophagus will look like as soon as you enter. There is a spine at 6 o'clock, and if you see the right side of your corner, you will see the lesser curve. So this is the right side. So this is the lesser curve. And if you see the left side, which is at 9 o'clock, is the greater curve. So this is the greater curve. So anything at 8 o'clock is greater curve myotomy. At 5 o'clock is the lesser curve myotomy. You can also do a myotomy anteriorly, which is known as anterior myotomy. And there are certain differences because if you do a posterior myotomy on lesser curve side, you will encounter sling fibers. While if you're doing greater curve myotomy, 8 o'clock, you will 100% break the sling fibers because sling fibers maintain the angle of phase. Our aim should be preserve these sling fibers. So that is why the posterior myotomy is always rule-based, that you must go to the lesser curve and not too deep. If you go too deep, you will cut the sling fibers. While anterior myotomy, there are no certain rules because you will never encounter sling fibers. So if you're doing posterior myotomy, be careful. At 5 o'clock, patient is in supine position. You can see the vertebral bulge there, and posterior is 5 o'clock. Greater curve myotomy, nobody does, but if the patient has a lot of scarring here, you may be doing that. Only advantage is there's a clear distinction between esophagus and stomach once you are doing greater curve myotomy. How I start? What is the length? I decide the length based on the HRM and the spastic things. And then I give 1.5 to 2 centimeter to the mucosal incision. Then I give 2 centimeter for a flap where we need to preserve the mucosa and muscle together. So anything, once I'm planning to do a myotomy, I add 4 centimeters. Say, for example, I am doing a small myotomy, 6 centimeter, 4 centimeter, I'll add 4 centimeter to it. And that will be the point of entry from the G junction. So in most cases, I'll start 10 centimeter proximal to it. But if I'm dealing with type 3, I have decided I have to do 15 centimeter myotomy. I must come around 19 to 20 centimeter above LES. So this is how I decide the circumference and I decide the length of myotomy. Now, once you are doing a myotomy, you can see these are very critical steps. So once I am doing a mucosal injection, I must be very careful. This looks a very small step, but it's a very important step where you must inject, try to squirt before you pierce, and then get a very good bulge. And that is very important to get a good bulge and then dynamic injection. As soon as you get the injection, you must direct the needle towards the lumen so that the subsequent deposition of saline happens in the submucosa. And once you do that, and this, if a good bulge, that's the best thing. And then you can have a mucosal incision. The mostly mucosal incisions are vertical, but sometimes a transverse incision have been described. So I'll go into more details of this to show you how to enter into. So once I started my poem in 2012, the most difficult part was how to get inside the tunnel. And then we realized that there are layers. Like you can see, this is the layer, second layer. This is muscularis mucosae. So unless you cut a deep muscularis mucosae, you will never enter into the proper submucosa. You can see you have to do layer by layer dissection underneath the mucosa as you do trimming in ESD. And unless you do this step, you may cause mechanical trauma while you enter. Otherwise, you may cause more extension of the mucosal incision by this method. So as I'm trying to get in, I'm trying to rotate the scope, but I'm not able to get in. So you can just increase by a millimeter and then you will dip in. So this is the most important step in poem to get into proper tunnel. As I said, there are many steps involved. So we'll see this. This is another again poem. You can see I'm seeing the esophagus 5 o'clock incision. And again, you may take help of certain new technologies like RDI to avoid deep vessels to make the incision very clean. If there is a bleeding right in the beginning, you are more worried to control the bleeding and you will apply coagulation and you will do more coagulation defect on the mucosa. So don't worry about the small bleeding. You can rotate the scope, bring the muscle anteriorly, or then gradually you can dip in. So once you do that, you are in a very good position. Now the submucosal dissection, which is a very easy procedure where you must do the dissection above the muscle. You can see I'm using a long knife and I can work from a distance, and my knife is directed toward the muscle because here my vital structure is here, mucosa. So I must preserve the mucosa. And you can see as soon as you get a big vessels, you not hesitate to use coag grasper because it may increase some time, but your field of visions are usually very good. Now, the second step comes is to identification of G junction. G junction is very important. So you may have a few landmarks there like aberrant longitudinal fiber. If you see aberrant longitudinal fiber, you are there in G junction. And then you can see on the muscle, these are spindle vessels. So the spindle vessels are again marker of gastric cardia and these penetrating vessels. So if you see spindle vessels, you see the aberrant longitudinal fibers and penetrating vessels, you are sure that you are into the stomach. Now try to go onto the right side, which is on the lesser curve side. And once you reach to the lesser curve, this is the lesser curve. You can see our tunnel is extending to the lesser curve. And to calculate the gastric length, it is very important. Sometimes as a beginner, you may use double scope method. Here I'm using a pediatric scope in the lumen and another scope which is in the tunnel. So then I go and see the length of my transluminal bulb on the prior scope and calculate the length based on the width of the prior scope, which is in the lumen, and I make sure that I am at least 2 centimeters into the stomach. Once I do that, I am sure that I have completed the tunnel work. Then I give 1 centimeter gap from the last end of the mucosal tier and then start doing myotomy. Myotomy is also layer by layer. You can see this. You can do either a full thickness right from the word go as he's being done here. Only thing is, here is the mucosa. So you must use a short burst of current. And as you arrive to the G junction and go towards the stomach, go to the lesser curve and try to go on the right of these penetrating vessels. As you can see here, you can see the fat in the peritoneum. That means you are inside the stomach and you have already calculated the length of myotomy by restricting the tunnel 2 centimeters into the stomach. Another way is to stop when the second penetrating vessels come, like here. And whenever there is bleeding, you can take the help of some of the technologies available to pinpoint the bleeding site, like red dichromatic imaging. And then you can see now this is the penetrating vessels. We went to the right. And then here, you can see this is the mucosal last part of the mucosa. And this much flap we have given. So this 1 to 2 centimeter flap is so important to prevent the leaks. And then you can make sure that the mucosa is completely intact, the LES is wide open, and then there is no mucosal breach. You can close this. The first clip should be applied to the normal mucosa, which creates a tent-like structure. and then you can do this type of. So these were some of the tips and tricks of doing poem. I will just quickly take a few minutes more to describe how I do in spastic esophagus. Presently, even if there is jackhammer's esophagus, the recommendation is to do LES myotomy and go into the stomach, because these are evolving disorders. Sometimes they can progress to type 3, and then you will have a big diverticulum if you don't cut the LES. The only drawback of cutting LES is more reflux, which can be prevented by the techniques which I told. And the length of myotomy we calculate by the spasm which are starting, right from, see, for example, 28 centimeters, the spasms are starting, and then we calculate this and do a long myotomies. These long myotomies are slightly difficult, but you can see the similar approach. Only thing is, because of these spasms, you can leave the sometime cap behind, or you have to be very, very careful about doing a very long myotomy. Cut the LES, very important. This is a slightly prolonged procedure. You may encounter more gas-related issues, but you may take some breaks and do this procedure thoroughly, because these are long tunnels and may take some time. So you can see this. These are very, very rewarding procedures. As you can see, this and as I showed the time barium esophagogram, you can see the 1 minute the level of barium was right up till to the throat, and subsequently there was complete clearance of the barium. So I think adverse event will be dealt with by my colleagues. We have more slides, but unfortunately I've finished my time. So I'll ask Truptesh and Amol to carry on with the further talks, and if there are time arise, we can discuss other points. So my topic was basically how to select the patient, what are the basic tips which I have covered, and subsequently we'll be able to discuss more.
Thank you, Mohan, for a wonderful demonstration of the basics of poem, how to select the patient, how to approach the procedure. And that is what we wanted from a master like you. And with that, we will move to the next talk in this session now, which will be delivered by Dr. Stavros. And Stavros will be speaking on poem in special situations. Over to you, Stavros. And we will definitely have time during the Q&A to discuss a lot of other things as well. So, Mohan, don't worry about that.
Yes.
Over to you, Stavros.
Okay, I hope you can see my slides.
Yes.
We can see them.
Okay, great. So thank you, Amol and Truptesh, for inviting me. Great to participate in this international poem seminar. The title, Technique of Poem, Special Situations, a bit, you can make what you want from it, I thought. So anyway, I picked 3 scenarios with 3 advanced poem techniques to discuss. First, poem, Salvat's poem for failed Heller with tight fundoplication, taking down the fundoplication. Then Salvat's poem in advanced achalasia with a patulous LES, but a sharp angulation caused by the diaphragm with our technique of peroral endoscopic urotomy. And then our latest technique with anti-reflux poem. Usually we apply this in younger early stage patients where GERD is more of a concern compared to dysphagia relief. So sling fiber preserving poem. I know Mohan touched a little bit on this. So first, first scenario is pale Heller with advanced stage achalasia and a tight fundoplication, taking down the fundoplication. So this is a case to start us going. 53-year-old man with achalasia for over 25 years, had the Heller in 2000, had incomplete relief of symptoms, but didn't bother to follow up with anyone. until 2016, when he was referred to us for salvage poem for residual symptoms. His ECAT score was 6. And his barium showed severe dilation, sigmoidization with poor emptying. And the impression based on the barium and our endoscopy and endoflip was that he had poor emptying for all 3 reasons. The anatomy now was pretty bad, and he had probably incomplete paramyotomy from the Heller, and he also had a bit of a tight fundoplication, as I'll show you. So we did a poem for completion myotomy and takedown of the fundoplication. So this is reviewing the anatomy of where those sutures are. So on the door, anterior fundoplication, the fundus is stitched. You can see the initial stitches, the first row to the left side of the myotomy, and the crush, and then they flipped over and you put this second row of sutures up here in the diaphragm right next to the liver. You can see here sutures putting the fundus right there next to the liver on the diaphragm and with the edge of the myotomy. So this is the anatomy, and obviously our approach is to remove those sutures on the right side there. So this is a abbreviated video of the 4-minute video that we published in 2017 as part of an article on poem outcomes in failed Heller. We had 45 patients then, and that was a video showing the complicated poem that you have after a failed Heller. So this is probably one of the most complicated ones we've done. So anyway, so this is a fixed narrow EGJ. You can see a blowout diverticulum from the Heller, typical for a failed Heller. And then you can see a food impaction ulcer over there. So, tricky poem with a lot of fibrosis when you see that. And then on the fundoplication side, you can see even 16 years later now, it's pretty tight with all the folds being sucked into the fundus there fairly tightly. So we start at 5 o'clock, a lot of fibrosis. I cut some of the submucosal tunnel dissection out to shorten the video. But we're completely to the cardia, and then we start cutting. Very typical of long-standing achalasia is this very thick muscle. You can see the area of the previous Heller myotomy where the muscle is missing, where we're next to it. And we encounter the band of the fundoplication here, pretty thick muscular band. So we can see how it splits into bundles because the muscle is pulled that way. So after we remove that, we encounter the sutures. You can see we're dissecting them just over the liver, which you'll see soon. So we're still getting the fundoplication here, very thick. And then you can see the sutures appear, and we start dissecting them. We inject the capsule of the liver really here. So you can see a little bit of coagulation artifact on the liver, trying to excise the suture, which here we did. So we remove the suture, and then you can see now the EGJ looks much more supple and soft and patulous. And then on retroflexion, where those folds were being sucked tightly, now it opened up. There's a bit of a hematoma on the mucosa. There's no full thickness injury. A little bit of a hematoma. So you can see at the start of the poem, the folds very tight in there, and now that area has opened up. So this is the technique, and then 78-month follow-up, ECAT score of 0, class A erosive vasculitis, he declined, bravo, this patient. So we have him on daily PPI. So just 3 slides on data, because we were told to focus on videos. So so there's some debate on whether there is a role for pneumatic dilation for a failed Heller. I don't think the poem is clearly better. There are 2 or 3 randomized trials showing that poem has the highest efficacy compared to pneumatic or even repeat Heller. But this is a randomized trial, so very level 1 evidence, 3 European centers, 90 patients, 45 and 45 randomized. The clinical success of the POEM blows the balloon out of the water, and the balloon protocol allowed 5 dilations, up to 5 dilations per patient with a median of 3, and still the success was 27%. Adverse events, nothing to write home about for both techniques. Esophagitis at 1 year, 34% versus 15%. But again, you know, if you don't disrupt the sphincter, you're not going to get reflux either. And then GERD symptoms and PPI use, interestingly, very similar and very high in both groups. So, you know, POEM is the way to go. This is from our oral presentation at DDW in 2024, 107 failed Hellers that we compared to naive patients, but also these were the results for the Heller patients. 94% clinical success at 5 years, median, nothing to write home about adverse events. GERD in the 50% range. And again, here we don't try an anti-reflux POEM. These people are looking at potential esophagectomy, very complicated patients, long-standing disease. We go for the biggest hole we can make to save them from esophagectomy. Now, this is the Hyderabad study, 72 patients, again, very similar, 88% at 5 years, mild adverse events, similar high reflux rates. And then this is a Chinese study from Pingongzhou, 81% clinical success at 5 years. They did have major adverse events requiring drains on these patients, and no GERD data reported. So, you know, very, you know, pretty successful endeavor. So now let's move to the second scenario, patulous LES, but sharp angulation caused by the diaphragm, where, you know, our technique comes in for the POEC. So this is what I'm talking about in terms of the diaphragmatic anatomy. So you have the right crus surrounding the esophagus, and the left arm of the right crus, this one, is pulling the esophagus a bit to the right side, indenting it and causing a bit of an angulation. This angulation may become more pronounced and consequential to outflow in advanced stage patients once the esophagus dilates and starts draping over the diaphragm and bulging out. This can become a more pronounced angulation that may impede outflow from the esophagus of food and barium. So what's the technique rationale? So for, you know, basically cutting part of the crus and weakening it and straightening that angle, well, you know, the crura have been dissected and excised by surgeons for years with impunity when they try to resect tumors that invade the crura. It doesn't affect, you know, respiration. In patients with outflow obstruction, attributable to the right crus, that offending left arm of the right crus can be identified during the POEM and easily cut by extending the myotomy of the intrinsic sphincter into the crus. In fact, I've seen some people have sent me videos that I telementor on POEM, and they have actually done it to a degree accidentally in some POEMs in your learning curve. So we first performed this POEM technique back in 2011. That patient is still doing well, 11.5 years, Eckhart score of 0, young woman. I did try to publish this in endoscopy 10 years ago, and I was rejected. But now we have 19 more patients to go after that one. Which is about 2.4% on the last analysis we did of 787 patients. So it's not a very frequent occurrence. All the stars have to align where the crus is the problem. So this is a case, 45-year-old woman with achalasia, man with achalasia for 8 years, also prior Heller in 2012, partial response followed by dysphagia recurrence in the past 2 years. He was referred in 2020. So Eckhart score of 8 in 2020, dysphagia 3, regurgitation 3, chest pain 1, and weight loss 1. Barium esophagram 5 centimeters with sharp angulation at the EGJ and slow emptying. Endoscopy findings, the LES appeared somewhat patulous, but it made a sharp turn around the crus. So the endoflip was pretty tight, 2.5 desensibility, diameter of 13 millimeters. So we proceeded with crurotomy. This is the video. So you go down the esophagus and you see the LES, I don't know if you can see, it's kind of open, but there's this big bump where things slow down, which is the cruise. So I mean the left part of the right cruise. So we enter, we inject, we enter. We always close with suturing, so we don't bother with a longitudinal incision. We go with a nice small transverse incision. So we dilate, I mean, we dissect small vessels, we do with a knife. And then we start with a myotomy. And you can see we do full thickness myotomy at the area of the sphincter, we always did. And then we you see after we reach the end of the tunnel, it's like about a 5 centimeter myotomy. That's all you need for type 1, type 2s. 5 centimeters, 7 centimeter tunnel, 5 centimeter myotomy or so. So we reach the end there, and you can see we exposed the cruise here, and it has this orange red salmon color compared to the white intrinsic muscle of the esophagus sphincter. So this is really part of the human sphincter, the diaphragmatic height is considered part of the human sphincter. So, but it's skeletal muscle. So you see it's all red, and you have to be careful when you carry because it jumps. So you have to manage the current. That's why it looks like it's in slow motion, and there's a lot of Kothari because you got to manage the current to avoid the spastic effect that current has on skeletal muscle. So we cut a little, and it's a bit of a cut enough, check and see if you need to cut more and titrate it to a proper opening. So we cut some, and it's not a complete crurotomy by any means, it's a partial crurotomy. So we go down, and now you can see now beyond the bump, you can see half the opening. Okay, maybe not the entire opening. So like, okay, maybe we should cut just a little more. So we can take a few more bundles. Again, it's a little slow to avoid the jumping. Okay, so few more fibers. And then you'll see suddenly, when we go check and see if we cut enough, nearly the whole orifice will be able to be seen without this shelf of the diaphragm in the way. So this is now, pretty good. You can see this flattened out here in the middle, the cruise. So we do end of lip, which confirms excellent opening, 8.9 distensibility from 2.5 and 22 millimeters from 13, the diameter. You can see on the right, you can see before, after, no more bump in the way. And then, we always close with suturing, as shown here. It's, it just takes, the average duration is actually 2 minutes, 2:20, but I think it's faster than lining the clips properly. So it's a bit of 3 pairs of stitches, and you cinch it. A little bit of bleeding down the side, but that gets cinched. So this is the crurotomy, and then you can see the emptying, the before tight angle here in the diaphragm, which then straightens out, and you even get some reflux from the stomach. It's like very straight shot. And the patient did great. Operative time 59 minutes. I said end of lip excellent. Barium esophageal rapid emptying, and latest clinical follow-up at 41 months was a CAT score of 0. PPI intermittently, heartburn episodes about once per week. 8, the sensibility of 8 is basically what our conventional POEM results in, about 8, compared to the anti-reflux POEM we do that I'll show you next, which is average 3 to 4 actually. So this is wide open. This is the summary of results from our 19 crurotomies. You can see these patients are patients with long-standing disease, 135 months average, lots of prior treatment, and half of them had myotomy. And then you can see basically 53% advanced or end stage, but the results excellent from median of 7 to median of 8, score 100% success with 50% pH positivity, 50% esophagitis, length of stay 3 days, no severe adverse events. So it may have a role in selected patients, usually patients with prior myotomy and or sigmoid disease in whom the sphincter, the intrusive sphincter was cut pretty decently, but there is a severe angulation in the area of the right cruise, of the left arm of the right cruise. So final scenario is the anti-reflex sling muscle preserving POEM when you want to reduce the incidence of GERD. Usually young early stage achalasia patients are good candidates for this. So this is our rationale for this, or for anti-reflux POEM. There's anatomic and 3D studies going back more than 2 decades that show that the human LES is a complex 3D structure which consists, this is from a cadaver, from these clasp fibers and these sling fibers draping around, which maintain the angle of His, which has an important anti-reflux effect. And in between, you can see these little black holes on the cadaver is where vessels enter, branches of the left gastric, perforating vessels. So this can help you identify where the sling fibers are. So we recognize this, interestingly, all the way up back in 2013. This is from 2 reviews I wrote on POEM more than 10 years ago. And this is a picture from that review where I said one could speculate that employing a posterolateral approach, cutting a portion of the posterior sling fibers, may achieve higher efficacy for dysphagia, but possibly at the cost of increased reflux. So that's where the idea originated, but we ended up practicing it in 2018 by being helped by Tanaka in Japan, who showed that these penetrating vessels that identify the sling fibers are very visible on POEM, and you can use them to identify and preserve the sling fibers by cutting to the right of them. And this is a video of this. I'll show you the myotomies. You can see 3 tufts of penetrating vessels every 1 to 2 centimeters. And to the left, you can clearly see the oblique fibers. And this is the sphincter itself. You can see the narrowing. So we start cutting the sphincter first. Again, more or less full thickness. And then we stay clearly to the right of these vessels. This usually ends up being at 2 o'clock or 2 or 3 o'clock, I'd say. So you can see here the nice tufts of vessels. This is our anti-reflux myotomy. You can clearly see that pink oblique bundle to the left of the vessels running down to the cardia on the left, marked with yellow lines there. So this is the technique. Now, what happens with the outcomes of that? So we looked at it by doing a case control study, because comparing 116 anti-reflux POEMs from 2018 forward to 116 conventional POEMs with a minimum follow-up of 2 years and 76% of patients having completed pH and EGD data at a median of 5 months after POEM. So you can see the percent of patients with positive pH study by Lyon criteria, more than 6% acid exposure, dropped from like the 60s to the 30s. This is not our overall series, 67%. It's the people we matched happen to have 67.5%. We matched them for age, gender, BMI, stage, type, to make sure that they're equivalent groups. Total acid exposure, 4.5% median versus 10.3%. Total number of reflux episodes lower. So, very good results. And I don't have time to show you the endoflip data, but as I said, median endoflip distensibility 3 to 4 used to be 7 to 8. So I did a live one. If you want to see the entire beginning to end unedited live anti-reflux POEM, I did a live one for ASG Live in April. It's in GI Leap at the ASG site. It's available for free. And it was moderated by Roberta Maselli and Mohan. And then we published it. So you can find the video also in this publication in IGIE, which is open access. And you can find the video and the description of the details of how we do the technique. Now, this is closing the talk by reminding you that this is the 15th birthday of poem in the US. This Monday, October 14, was the 15th year. I did the first one in October 14, 2009. So 15 years of poem in the US. And the IGIE just published a historical perspective about the beginnings of poem. If you're interested in history, there's some interesting anecdotes over there. Yeah, Philip G removed the most politically incorrect anecdotes that I had put in there, but it still left some interesting ones. And then thank you. And this is used to be my bulletin board in my office. My secretary has started putting thank you letters from poem patients. I think the only procedure I get thank you letters from, more or less, and you can see that this is like just maybe 20% of them, and we still try to squeeze as many as we could. So very fantastic procedure. Patients are the most grateful than any other procedure, and I'm very happy to deliver it to them. Thank you.
Thank you very much. That was an excellent lecture, and we thank you again for starting poem in the United States. And moving on to our next lecture is Dr. Ahmad Madkour, who's going to speak about a case scenario of the mucosal injury and how to deal with it. Ahmad, all yours.
Yes, hello everyone. Thank you, Trux. Thank you, Dr. Amol, for the kind invitation and organizing this wonderful event. I enjoy all lectures, and my task today is to talk about mucosal injury as one of the complications which may encourage during poem. Actually, mucosal injury is not uncommon. This was a nice review for classifying the mucosal injury. It may be only just a scaly mucosal injury or submucosal exposure or a complete perforation like this. And this was a nice paper that carried out on about 2,000 patients, which classify mucosal injury either type 1, which have a different shapes, or type 2, where it's a complete perforation. The type 2, which is a complete perforation, is not common. It's only 1.7%, while total mucosal injury is around 17%. The risk factor was hilar myotomy, previous poem, or fibrosis, and long tunnel. All these was risk factors. For type 1, you may have some debates if we should clip or not clip this defect, like here in this type 1 mucosal injury. But in type 2, we must clip. We must clip in type 2 or must close. Usually we use hemoclips also. And this was our paper published in Endoscopy. It was a video about using the clips to close the defect from inside the tunnel, not from outside. Sometimes when we try to clip from outside, it's difficult to approach the cardia, which is the most common site of mucosal injury. We may need a lot of clips. But when we try to clip from inside the tunnel, it's more precise. We use a fewer clip and we secure a tight closure. Here we have a complex mucosal injury in a patient who underwent previous hilar myotomy and severe fibrosis. And if we look here, we can see the mucosal injury very clearly. From inside the tunnel, we depend on suction. We just place the clip like this, and we do a suction and let the edges inside, and we fire the clip. And if we look again from outside, actually it's totally sealed and folded inside. And this was a follow-up for this case, and we couldn't find the clip in X-ray. And we didn't find the clip when we do the endoscope. And we have another case also. At this time, we published 2 cases. In case 2, we have more simple mucosal injury. Here we didn't do myotomy yet. And this one was a small mucosal injury. And again, we use a hemoclip. We added tangential. We depend on suction and close and fire the clips. And it secure a tight closure. And then we perform the myotomy. And again, if we look here, we will find a closure of the mucosal injury, but from inside. But in the follow-up of this patient, we found an interesting view. If we look here, we will find the clip. Actually, it's spilled outside. And we think that what happened also with the first case. If you can look here, you can see how the hemoclip look like. Actually, when the tunnel collapse, the clips come out to the lumen and it fall back. In the previous case, in first case, we didn't found. Here, we found here like this, and we simply remove with the foreign body. I think we may need more cases to ensure the safety of this approach to close this mucosal defect from inside the tunnel, but it's good to try, especially with complex cases. Here we have one more case. This was this year. And again, we have a complex mucosal injury. We have a trainee who tried to perform some of his first cases, and we clip from inside. But after we clip from inside, we should look again from outside to make sure it's tightly closed. One important tip here, just to use a clips you can rotate yourself. So Boston clips is very suitable for this. So you didn't have an aggressive movement, which increase the mucosal injury. And if you look here, it's closed, but you still can see part of the clip here. So we need to do more closure for this. So we move to try to close. That's what we talk about. Sometimes it's a complex to approach this defect from outside and to place the clip from far away. And here, after it's already approximated the edges, we will clip from this position. This approximation because of the clips which already placed from inside. And then we will place some more clips here to secure a tight closure for this complex defect. We should be cautious not to increase the defect. If we just push the clips, you may cause more mucosal injury. So we depend on suction to let the mucosa come inside the clips. Then you gently close and you can secure a tight closure for such defect. We still depend on suction like this, then we fire the clips. And this also the best way to deal with a small muscle injury, to use suction to let the defect inside your clips. And we add one more clips here. Finally, this was also a nice method that was published from China to use a fibrin salate to close a mucosal defect. When they have a mucosal defect, they just add a fibrin glue inside and leave it, and they publish around 16 cases, and all were effective to be treated by this way without using any clips. By the end, I always like to thank my mentors from São Paulo, Brazil, and from China, and my team, and thank you.
Thank you.
Thank you.
So I would like to,
Yeah.
yeah, Dr. Bapaye is there. Okay, carry on.
Thank you, Ahmad,
Thank you,
for,
Dr. Amol.
for a wonderful presentation on various types of mucosal injuries. And for the last talk, may I invite Dr. Carlos Robles-Medranda. Welcome, Carlos. We missed you at the initial introduction, but we introduced you, and everybody was looking forward to meeting you online. So we would like to hear from you about how to control bleeding during POEM. So over to you. Thank you.
Thank you. That's a very good topic. So thank you so much for this kind invitation. I don't know if you can see my presentation.
It shows.
Can you see it?
Yeah.
Yeah.
Can you see it? Okay, perfect.
Yes.
Can you hear me well?
Yes, we can hear you well.
Okay. Okay, perfect. So I will talk about bleeding control in POEM. So we already know that POEM is the gold standard technique right now about for the treatment of achalasia and other esophageal disorders with great long-term clinical success from 80 to 90%. Is a good therapeutic option used for motility disorders such as achalasia, thinker diverticulum, gastroparesis, among others. The complication rate of POEM is between 5 and 10%, including gas-related complications, mucosal tears, and bleeding. So I will talk about POEM bleeding control, and I want to summarize what we can do during or this kind of situations. So we have electrocautery hemostasia by using the forceps, right? Nowadays we can use microwave technology, incorporating some kind of devices when we are using POEM, when we are doing POEM as a cryomedical, the knife. So also we can use balloon tamponade treatment in some kind of cases when the bleeding is under non-controlled by standard techniques. And we can have also other kind of techniques in certain cases as mechanic clips or sutures or stents. So hemostasia have a higher effective achieved by bipolar forceps than hemoclips. And it's something that we know nowadays. So we have a very good study showing this. But even if we have less better results with hemoclips, it doesn't mean that we cannot use it in certain kind of cases. For example, in some cases when we do not achieve to have a good bleeding, different kind of technique we can apply it. And one of them is this is using small clips, in certain cases when we cannot achieve good hemostasia. Other techniques have been used, not a lot in POEM, but in some kind of cases we can use also, hemospray. So I want to show some cases. So this is a 64 years old female with type 2 achalasia who underwent to POEM on July 10, 2021. During the procedure, supracardial mucosal defect was observed, and 7 hemoclips initially were used, for closure resolution, without resolution, but then a fully covered stent was fixed using a Ovesco for adequate closure. Post procedure, the patient present with hematemesis, hypotension, hemoglobin level, requiring blood transfusion, and a new procedure was done, showed distal stem migration and Ovesco detachment. So this is the case. So in this case, what we do it was to remove the stent, because even using the stent as a kind of tamponade treatment didn't achieve the results that we needed. And this is one of the difficult parts when we have some kind of bleeding. And what we do in this case was trying to achieve hemostasia using Ovesco, because in this case it's not an acute bleeding, and it was not acute bleeding, it's a delayed bleeding, and it was not, we didn't have the access, by the tunnel, and now we need to deal with this situation. So we find out the area that were with the problem, and then we close very efficiently the bleeding. We stop the bleeding. So this is a second case. This is a 63 years old male with type 2 achalasia who underwent a POEM on May 2022. In our unit during the procedure, 7 hemoclips were used for the tunnel closure, but post-procedure, the patient refers hemostasis, hematemesis, and melena. So what we happened with this patient was probably one vessel in the incision area was not well coagulated and was not observed during the POEM, and then a bleeding was observed, in the area of the incision. So what we do at that moment was to remove the clips, and then we use some kind of argon plasma. You need to remember that we have 2 centimeters from the incision to the myotomy area, so it was really safety to do it. So you need to think about it. It will depend where is the area, where is the area of the bleeding, and what was the situation of the bleeding. So this is another case that we have, very, very complicated case. Was a 19 years old female, required hemostatic clips and partial covers self-expandable metallic stent for distal esophageal mucosal injury closure that was bleeding at the beginning and also after POEM. So this was a case that had severe damage because of avascularization of this area. So the bleeding was not just because of the vessels surrounded, but the open and the perforation, the delayed perforation, was because of avascularization. So we had a big complication with mediastinitis in this patient, but we tried to do some sutures, and was not the best technique, because the patient is still bleeding slowly, but at the same time we had this perforation. So we decided to treat this patient by vacuum therapy, and you can see how this patient recovered, fully recovered after that. So it's one of a good alternative that you can use it. There are some reports for using endoscopy or vacuum therapy with Vesco also. So this is another case that we had, was a 66 years old male with a Senker diverticulum and Z-POEM, and we used 10 hemostatic clips were placed, but leakage remaining, and 4 clips were removed, and 5 additional clips were put. So the ideal of the technique is avoiding to have bleeding during the procedure. I like to use spray coagulation a lot because it makes me feel a little bit more comfortable regarding the management of the vessels with a single device and quickly. But sometimes we can have this situation, and in those cases, do not repair that. Sometimes you need to change your strategy, or using a small clips, the 8mm clips inside the tunnel, because sometimes the muscles bleeding also. We had one case once with Michelle Cajela during some cases that we were doing in Ecuador, that the bleeding was coming from inside the muscle. So in that moment, nothing, tamponade, nothing was enough. So using the cap and given a pressure of 5 to 7 minutes, just with the scope in the area was bleeding, it stopped the bleeding. So it is very important to understand this. In some cases, small pediatric patients, we can use bronchoscope and doing the treatment, and we can stop bleeding also in the same way during using hemostatic or using forceps or using the same knife. This is another case I think was very interesting to show you. Was published recently on Video GIE. It's a 53 years old man with achalasia, post-heller myotomy 12 years prior, presenting with worsening dysphagia, regurgitation, and 50 pounds weight loss over 2 years. And the esophagograms showed that the contrast didn't pass. So there was endoscopy was performed and demonstrated a dilated sigmoid shaped esophagus with a protonic lower esophagus sphincter. So in this case, the authors showed us in some cases with sigmoid lesions, we need to use the balloon that we use it for dilation to achieve one tamponade control. And it's very effective. At least we don't have data from literature. Maybe in retrospective multicenter study we can have something. But in this case, you can see sometimes it's very difficult, even using the hemostatic forceps. And it is because we need to understand that many times the muscles, the vessels are coming from inside the muscle. And that is the big challenge of this technique. Sometimes you need to cut a little bit more just to identify where is the bleeding. But even when you are cutting, if the vessel is coming from deeper, sometimes the vessels, become short, so it becomes difficult. So in this case, the authors finish the procedure, but then they use the balloon tamponade. You need to pass the balloon inside the lumen of the esophagus, and they achieve the hemostasia after the treatment. So as a take-home message, in bleeding post-poem, we need to identify what is the cause of this. If this is acute bleeding, we will solve most of them, I think 98%, just by direct access with bipolar or electrocautary hemostatic devices. So we can use also small clips, short clips, 8mm clips in some kind of cases if it is necessary. So we can use spray coagulation, we can use hemostatic forces, we can use microwave technology if we need it. In case of bleeding because of a vascularization postponement that could happen, so probably sutures or clips are the best option if we have good control of this. And bleeding by other causes with difficult treatment, sometimes tamponade or stem placement could be a good alternative. So thank you so much for this invitation and for this amazing course. So I am available for any kind of questions. Thank you.
Thank you, Carlos, and wonderful cases and great demonstration. So we have about 20 minutes for Q&A, and I think there are quite a few questions that even I have after listening to all your talks. And so my first question to all of you all is, what is, as experts, what do you think? And all of you all have been pioneers in starting poem in your area. So for a beginner, for a person who wants to start poem, what do you think is the most, crucial inhibition or a bottleneck to start poem in their practice? So maybe we can have, responses from each one of you all, Mohan, Stavros, Ahmad, and Carlos, in that order.
Well, I want to start with that. That is a very good question, and I I had some trainings that I received here, not like in India, that you have more and more patients, as Mohan, for example. We have amazing series, but we have at least 100 patients a year. That is, it's a good number for us. Um, what I always say to any kind of fellow that come to me to make a training in third space, I need that these fellows at least know very well how to do hemostasia and how to solve complications. It means therapeutic knowledge about how to make, control perforations, how to use devices, and all these things, because this is very important. Poem is a technique that you can teach anyone. It's not. I don't believe that it is a very difficult situation. The problem of poem is to deal with the complications, and the fellows need to be prepared to that. We can teach in a best way and better way and faster way, but just if the student have at least this knowledge. This is the minimum for me. I don't know how the other experts say, but for me this is the most crucial.
Thank you. Mohan, you have your thoughts?
Yeah, so the question is, what is the most important inhibiting factor where, there can be many. I think working in a team gives a lot of confidence and having a constant work volume is the two crucial thing. And third, having a basic scope control by having a good background teaching of endoscopy, maybe with a good colonoscopy techniques, with good endoscopy technique, with a team, with a good surgical and IR backup. I think these are some of the prerequisites to start. Standalone people, I have seen, they go to many conferences, but they are not able to kickstart them. But if you have a unit where that if there are any complications or anything, they can be taken care, or if there is any issue, there can be some second person can help. So these are some of the things which I see very important to start this type of procedures. And once, as Carlos said, this is not a very difficult procedure. Once you get hold of it, to get into the tunnel and then have a proper delineation of mucosa, submucosa, it's a straightforward procedure. And I think it can be a gateway to start more difficult ESDs and other things. So I think with these prior prerequisite, I think anybody can start such procedures.
Thank you. Stavros, you have any comments?
Well, I agree. The important thing is volume and experience. So you have to do it as a piece in an esophagology program that includes a motility person that understands achalasia and esophageal disease, and a surgeon an MIS surgeon that can be a partner, and that sees maximum safety and will bring the volume to accelerate the learning curve, because everybody says how easy poem is, but you know what? Yeah, it's easier than ESD, but it's more dangerous than ESD. I know of several deaths from poem. I don't know. I haven't heard of any death from ESD. I mean, and I'm talking intraoperative deaths. So easy doesn't mean, let's go start with that and explore some of this mediastinum, So it has to be, all of the US maybe has 2,000-3,000 poems a year. So you can have, 3 poems each for 1,000 operators. So it has to be part of a program that ensures high volume. And my bias is that, like major academic centers, the poem should be funneled to one person so they can get good fast and minimize the risk of complications and improve efficacy.
So just to add to that, Dr. Stavropoulos, is we know that most of the procedures for POEM, they are not covered mostly by insurance at some point, and the reimbursement that we get are not that great. So we would like our audience to know that how did you start that, and what is the advice for people who want to start POEM programs at their hospital, and what is the mode of approach for reimbursement, etc.?
For poem, it's simple now because there's a code. We don't get any denials. Like from 2014 to 2017, practically every poem was denied. So appeal letters, external reviews, peer reviews. About 2017, 2018, that stopped. So poem is pretty much secure. I do get problems now with Zpoem, okay, more than Zpoem, and I get problems with ESD, EFTR. So you got to use an unlisted code in the US that then gets billed with an equivalent surgical code. The minute the insurance is an unlisted code, you have an issue. So there you can work with the whoever are the bigger insurers you have. You can talk to the medical director and give a presentation about what the benefits are compared to, say, getting surgery, and try to convince them to accept the unlisted code. The reviews are not great for ESD because depending on what code you use, it could come down to, I don't know, 2-3 reviews per hour. But it's you got to balance it with easier procedures some part of your time to sort of subsidize the situation.
Okay.
Ahmad?
Yes. So
Any challenges?
yes, I agree on everything said. It's easy and dangerous. I totally agree on this. It's easy, but it's dangerous. I don't advise anyone to start without supervision, even if he have a good tip control and if he can deal with complication, because the orientation of structures and the planes is very important. You are dealing with structures around you. It's very vital. So you should observe a lot and you should have supervision in first 10 cases. So you are oriented with the plans and the structures around you, then you can go on. It's more easy and it's more dangerous. Just keep this in mind.
Okay. I think
Thanks. There is a question from our audience. I would go with the first one is, what is the best setting for myotomy, including the VO3? It's open to all.
I use precise sect and spray coagulation equally, 50 watts. So precise sect is an intelligent current where the problem with myotomy is that you are cutting a muscle and there are hidden vessels and then they can bleed a lot, and then it is very difficult to control sometimes. But if you use intelligent current like precise sec, these small vessels which are hidden, which can be very easily dealt with, because that current can deliver the coagulation based on the impedance which it meets. So I think precise sect is a very good. If you have a YO3, I recommend precise sect.
right. There is a question: which size balloon should be used for balloon tamponade for myotomy bleeding? Well, I would say that using a balloon for tamponade myotomy bleeding is just once in a while. It's once in a blue moon. Meaning, we would rather try and control it very effectively with a coag rasper. But in case one needs to use it, what kind of a balloon would you use?
Well, that is a very good question, and I already mentioned it a little bit about the using the balloon for balloon dilation achalasia. So you need between 30 to 35 millimeter balloon, and then you need to stay there at least between the 2 minutes to 5 minutes to get the tamponade. So it's not difficult. You need to pass the guide wire through the esophageal lumen, and after you do it, so you decide, it will depend of the diameter of the esophagus. That is that.
Right. But would you pass the balloon in the lumen of the esophagus or inside the tunnel? Because that is very important.
No. In the lumen of the esophagus. Inside the tunnel is
Yes.
complicated. Yeah.
Yeah. There may be a mucosal laceration. I thought as much.
So
Truptesh?
next question for Mohan and Stavros is there more risk of bleed in POEM for spastic disorder since tunnel is long and muscle layer is extra thick?
I don't think so, because obviously if you are dissecting too much, you may encounter one or two more vessels, but I don't think spastic disorder per se will cause more risk of bleeding. I have not experienced that. But as you said, since there are longer length of dissection, more number of vessels will be encountered, but that's okay. But it can be controlled. That's not a risk factor for more bleeding.
Yeah, I
Yeah,
agree. I agree.
totally agree.
There's no more bleeding for spastic than non-spastic. The main thing with those people is insufflation problems, because the muscle is very thick, and without realizing, you spend too much time cutting the muscle, and then you get CO2 escape, and you can suddenly have a tense capnoperitoneum. These are the most likely patients to get the tense capnoperitoneum, at least for experienced people. I don't know, Mohan, I think you agree, right? Yeah.
I agree. Exactly. As I said, more time you spend in the tunnel, and we do not have a CO2 insufflator which has got negative feedback. So you keep on injecting too much of CO2, and then that is directly proportional to more CO2 related adverse event as compared to bleeding. I don't agree bleeding is more, but I agree that CO2 related complication does happen more often.
All right. So there is a question that to Ahmad, when the mucosal injury is closed from inside the tunnel, is there no chance of the clip going into the peritoneum?
Yes, so this was a question, and that's why we asked when we publish an endoscopy to mention we need more study for safety on this. But actually, we have a serosa intact. We didn't do a full, we just, after we cut the muscle, it's not open to the mediastinum. We have the adventitia and have the serosa, and in the 48 hours, this tunnel collapse. Once it's collapsed, we keep in mind the concept of poem F, where we leave some clips inside. So we say it's the same. But actually, what happened here, all clips come out. It all came out to inside the lumen. Some we found, some we didn't found with X-ray. It looks to be safe, but should also we have some experience about this.
Right.
So
Thank you.
one question I have is, which patient would you refuse for POEM? And just one more question with that is, do you use endoflip for every patient?
Can I answer? We don't have endoflip, so endoflip, I think Stavros can answer better. But if a patient has large hiatus hernia, young patient, I will straight away refer that patient for lap Heller's myotomy with crural repair rather than me doing POEM in that case. Otherwise, most of the case I will say I can do the POEM. But that's, I don't want that
Technical
patient.
difficulty, Mohan, like submucosal fibrosis where you cannot get an entry at all. You know,
But yes, I will attempt that and do, because submucosal fibrosis, good thing is that it is never, uniform or completely not doable. You must try that 4 or 5 places and you will get some window. But that cannot be a strict contraindication. But as Truptesh was asking, where straight away you see a large hiatus hernia and then young patient, you don't want to cause more, reflux and cause more Barrett's, more cancers in that. I will prefer to be lap Hellers in that case.
From my side, just to complement the comments from Mohan, is that what I do is some kind of patients with a lot of infection by fungi infection, candida infection in the esophagus. If I see a lot, I stop. I didn't try, because in those patients there is a big inflammatory situation, so you cannot get access to the third space. So this is very important. I believe it's most common than diaphragmatic hernia or these kind of situations that as Mohan already mentioned it. But in those kind of patients, I stop the POEM. I explain to the patient if I see one kind of this situation, so I will stop. I left one nasogastric feeding tube, and then I pass treatment, and I retake the patient after 15 days, because after 15 days, the inflammation is gone. You can have some fibrotic areas, but you can do it. So I do not recommend to do it during big infection of Candida. So in those cases, I believe you need to. It's not a complete contraindication. It's just a relative contraindication to do at the point during the procedure.
Thank you. And probably Stavros, you can answer Truptesh's question on the endoflip. And regarding the endoflip, I have one more, that the distensibility index of more than 6.5 has been considered to be a risk factor for post-POEM reflux. So meaning some of your videos and cases, you showed that the DI had gone up to 8 and 9. So any thoughts about that? Or that is again another.
So that's one of the utilities of endoflips. I do endoflip on every case for the last 12, 13 years. So we have hundreds upon hundreds of endoflip measurements pre and post POEM, and then we do it when they come back for the Bravo. We do it at 7 months or something. So you can actually see that the distensibility before POEM is less than 2 or 1. Then it jumps to, it depends on what POEM you do, but 4 to 8. And then at 7 months, it's down to 5. So things tighten up, and we have shown that the reflux drops also with time. So it's very, very good to monitor quantitatively what are you doing and how the EGJ is remodeling. It's very useful on previously treated patients. Like you get this classic failed Heller patient, and you go down and you eyeball the open, you're like, I don't know, is it open enough, not open enough? If you get a distensibility, like when we presented our post-POEM, post-Heller salvage POEM data, we had 6% failures. The median distensibility before the POEM in the failures was 5 to 6. The median distensibility on the 94% where the POEM was successful was 3.5. So it gives you immediately an idea about whether this patient should get a salvage POEM, or maybe their problem is just sigmoidization and opening up will not make a difference. Now, having said that, for treatment-naive patients, nice patients, we're worried about reflux. Now we get to 3 to 4 distensibility. The one I showed you that showed an 8 was the guy that had problems after a Heller and was already getting sigmoid. These patients, you have to err on the side of saving them from an esophagectomy down the line. So we don't try to make the orifice small. So we go back to a distensibility of 8, which used to be our median distensibility back in the conventional POEM days. So you can tailor the myotomy to the patient. You have a young treatment-naive woman, she's thin. Her chance of reflux by being thin, female, and young is minimal. You can do but you can still do an anti-reflux POEM, so it doesn't have to be on PPIs, right? If you get like somebody that had the previous Heller and now the esophagus is stage 3 or stage 4, and maybe in 5 years they'll need an esophagectomy, or 10 years, you gotta go crazy and make a big opening. So you can tailor the myotomy, and the endoflip allows you to tailor it with some quantitative data.
Okay.
Sounds good. This is a question for Ahmad. One of the videos shown by our experts that, and the question was posed on that video, is that the 2 penetrating vessels should be spared or prophylactically coagulated.
So actually, I did around 300 poems. It's not always that clear. I'm not sure if I am the one who missing, or this is the standard. It's not always very clear to see the penetrating vessels and be sure they are the penetrating vessels and not just a submucosal large vessels and isolate. So usually I coagulate if I will cut in the way. But if they are away of my tunnel, I can go beside, I will leave alone. This is the general concept in any vessels in the way. But it's not always so clear to found and isolate those penetrating vessels.
Okay.
Well, the penetrating
Anybody else?
vessels are in the same place where they are, also on cadavers. Whether you see them or not depends on which orientation you take. You can take an orientation that altogether doesn't expose them, or you can take an orientation that exposes them, but then you decide to preserve them, or you can expose them and not preserve them. I preserve them anytime I can because these are up to 1 to 2 millimeter arteries that are branches of the left gastric. So why mess with them and cause immediate bleeding or even some risk of delayed bleeding if you don't have to. So I only get them when I don't, because I pick my orientation, and then because of fibrosis I end up going too far to the left. So I end up having them in the middle of my path. I still try to squeeze to the right of them, but if that's gonna take too much effort, I coagulate at least the first tuft, and then by the second tuft, I may have been able to successfully move to the right. So yeah, so you should avoid coagulating them if you can, unless you happen to, because your tunnel kind of veered off a little, you really have them smack in the middle, and you can't really avoid them at this last moment. So then you can coagulate at least the first bunch of branches.
Thanks,
I don't know
Doc.
if Mohan agrees or I don't know.
I agree that if you need to do a wider dissection to open that, but as we are gaining experience, we are already going, as you also showed in your reflux preserving poem, where you want to go up till 2 to 3 o'clock, where so you will never get those penetrating vessel if you are tuned in such a way that you are going to 3 o'clock. So you know that you are already preserving the sling fibers, and you will not do a wider dissection to expose these tufts. So gradually, as you are gaining experience, you are more towards 2 o'clock, and you will not find those vessels. That's what I also agree with, that you may not find unless you do a wider dissection, or you are at 6 o'clock and doing a wider dissection and then choosing the path to go right. But if you're tuned to go to right, then you may not find that.
All right. So just one last question, probably we have plenty more, but we'll probably have request the faculty to answer them in the Q&A box. So there is one question which I would like you to answer. Maybe Mohan, you can do that. What's your take on partial thickness versus full thickness myotomy? Because I know, you've published on this and earlier, and now your thoughts are different. So I wanted to hear both the thoughts, that kind of a thing.
So we started doing anterior myotomy for first 2-3 years. And that time we were very scared about the pericardium. That was in 2012 and 13. So we trained like that we go, and we were like medical gastroenterologists doing first time surgical procedure. So we were really scared to see the pericardium or open mediastinum. So we always wanted a depth perception. Like, this is the longitudinal muscle. I don't want to go unknown territories into the pericardium or anywhere. So I used to preserve as a marker of depth, not like to preserve. If you preserve one longitudinal fiber, you will still 99% are still intact once you're doing separation of longitudinal fiber. So ultimately, it did not matter. It made the procedure quicker as I gain experience and I had more depth perception, and ultimately no change in the response, no more reflux, but in fact, it made my procedure faster. So I started doing preservation of longitudinal, but they realized that it's not more important, and I can finish the procedure very quickly if I do complete myotomy.
Okay. So with that, I think we are beyond time already on the.
Amol, I think there's one interesting question that I would like the answer of you experts on, which was by Nikhil Kumt. I don't know if you saw it. What about when you have a dilated sigmoid, terrible megaesophagus patient using the overstitch to plicate it into a It was asked by Nikhil Kumta, placating. The Mayo Clinic, I think, published a few patients. I don't know if they published any follow-up, where you take the overstitch and you do almost like a sleeve gastroplasty on the esophagus. Has anybody tried that? Because I haven't tried because I have concerns about this whole thing. I don't know if somebody has tried it.
I have never tried it. Speaking for myself, I never had the need to actually. So to think about that. But the reason why I answered that question on, in the chat box, but did not take it because I think the majority of the audience want to focus on the poem and poem technique as a standalone. And that's one of the reasons I also ignored Nikhil's other question on poem F. And I answered that because I think
Okay.
it be a different topic on its own, because when we are talking about reflux on poem and things like that, because otherwise we can do a full day of session on poem and this can go on. So that can happen. But I think with that, it brings us to the end of this wonderful webinar. And I would like to take this opportunity to thank all the speakers, Mohan, Stavros, Ahmad, Carlos, all of y'all for taking time out on a Saturday for this important session. And on behalf of Truptesh and myself, I would also like to thank Boston Scientific for supporting this webinar through an educational grant, without which this would not be possible to run this every 3 months or so. And of course, we would like to thank all our participants who have been, attending this webinar. And we also know that, although many people register for the webinar because of time zone constraints, they may not be able to attend the webinar live during the session itself. But for that reason, this webinar is completely recorded, and the recording will be uploaded on our YouTube channel, the Free Endoscopy YouTube channel, in a couple of weeks' time. And we would request you to subscribe to the YouTube channel, the Free Endoscopy YouTube channel, so that you all are updated on the new content in the channel. And with that, I would like to announce our next topic. The next topic for our webinar for the East Meets West will be lessons from the quarry, management of difficult CBD stones. And of course, keep looking out for the space for the date and the faculty of the webinar. We will get back to you very shortly on that. Truptesh, you have any last, comments? You can go ahead, and then we will close off from here. And thank you so much.
I
Have a
just
great
want to thank all the faculties coming, and definitely we are already 5 minutes out. So we would wrap it up, and have a nice day and have a nice weekend. Thank you all, and thank you to all the attendees as well.
Thank you so much, Truptesh. Thanks.
Thank you.
Thank you.
Thank you.